we reopen our research activity. Now we have masks. We did the same photos before with some of the people are here, but now we have a mask. But you can see volunteers or patients that we are doing now on our device at Bordeaux University. Next. I was interested to look at two studies that have been done. One in Wuhan, with one of the earliest published study in the American JAMA, and it was done by a team that I personally visited in Wuhan several years ago. So and they produced this paper on the 214 patients. And what they show is that around 36% of people had a neurologic manifestation, and they include dizziness and headache. And you can see 13% of people were complaining headache. And smell was impaired in 5% of the people. And finally, on those people that had a severe disease, they had only 2.8% of acute cerebrovascular disease, which is pretty low. I compare with a paper that has been recently published in the Journal of International Medicine, about 1,400 patients in Europe, coming from all our countries actually. And interestingly, the headache was 70% of the population. So it shows that this is the number one of the symptoms in the patients. And even more than fever, that was only 50%. So it's interesting. The population is different. Those are mild to moderate patients with COVID. The other study from Wuhan was with the severe patients. And the smell impairment is 70%. So you can see also a big difference. And so there are many questions about those differences. Maybe because Asian population are different than the European population, so symptoms are maybe different for that. Maybe the ACE receptors are different according to the different type of population. So there are many questions about that. Besides this, next slide. In fact, there have been several papers that show, and a lot of single cases that show abnormalities in the brain. So here I summarize what has been found, and you can see that there are many different type of situations, and in few cases. So it makes me feel that the CNS involvement is more like a side effect of the general involvement. And this is my feeling. And I don't feel that the virus is really targeting the CNS directly, because you have all those imaging and those different kind of images on a low number of people. Next slides. So I can show you now, it's almost the same than were shown by Luca. Before, there has been cases reported with small infarct where the arrows are, or on the star in the cerebellum. Next slide. And of course, acute thrombosis, but when you see the thrombosis of the basilar artery here, concomitantly there were thrombosis in many organs, including the pulmonary, including in the aorta wall, and also in the kidneys. So you think it's a more general process that is affecting the brain. Next slide. Yeah, and also T2 hyperintensities have been shown in patients in ICU, but their pulmonary conditions may account for the low rate of oxygenation in the deep part of the brain. So is that specific, or is this more likely related to the situation in ICU? Next slide. Again, there are cases of suspected meningitis or encephalitis, but it's difficult to make sure those cases are a direct encephalitis or a reaction to encephalitis or even a small stroke. So those has to be confirmed. Next slide. And also maybe ADM, which is a reaction to the virus that usually happens several days, usually a week, at least a week after the infection. And there has been cases showing that, but again, this is not a direct involvement by the virus. Next slide. And of course, the cytokine storm that can bring the acute hemorrhagic necrotizing encephalitis, but usually those patients have cardiac problems, pulmonary problems, and SARS, and etc. Next slide. So in Bordeaux, we had those cases in ICU on the left with probably ischemic condition and due to hypoxemia. And we had one case of maybe DM or thrombosis of small vessels. Next slide. So, so to me, what I see is that for the neuro, we don't have only one or two or three single disease. We have a spread of different conditions. And for that, I've proposed, and we have been talking with the Canon team about which sequences to do in the acute phase and maybe which sequences to use in the subacute and the chronic phase. And you can see that we move from the one which are really directed to the disease, but we still keep some of them that are the key sequences for neuroimaging, but also optional sequences for research, because we don't know exactly what is going to happen in the brain of the patients. And so I think that 3DT1, for an example, is interesting to look at brain atrophy. And I join what you said, Joseph, to follow a group of people over time, and optional sequences for DTI, because maybe there are some affection in the white matter, QSM for the iron deposition, and double diffusion encoding to have more quantitative data about the diffusion.